Okay, I think it's enough time for move to the next lecture. This is Dr. and please to invite Dr. Daniel Nevo. Okay, there will be interesting statistical approaches that I'm very curious to hear them. So you'll present the title, Daniel.
Thank you very much. Yeah, I'm glad you already said it's interesting. So, yeah, is this thing working? Yeah, okay, surprising. Okay, so I'm going to talk about estimating vaccine causal effects from observational data. And I've included this photo. Yeah, I won't be able to use the laser. I've included this photo taken during a morning bike ride in the first lockdown to remind myself and ourselves how little we knew and how much we need to learn and we've been learning in the past 2 years, but also to remind myself that more than 2 years passed and I need to buy new bikes. So yeah, so I want to start with a full disclosure. My typical talk to my typical audience look like something like that, you know, like a bunch of equations, propositions, theorems. Yeah, exactly. Yeah, so this is my typical talk. And while so I feel here a little bit like, you know, like an Englishman in New York. So I'll try to have zero, I mean, it's a guarantee, zero equations today, but I still want to talk, and what I want to talk about is challenges and methodological aspects of estimating causal effects from observational data. And given all the introduction we had today, I think we agree, or there is at least majority in the room that agree that the #1 weapon in our arsenal against COVID-19 is vaccines. And we know, you know, a randomized controlled trial showed that it works, but a highly controlled system. And how do we know that they work at scale? The answer is observational studies, huge observational studies. And thanks to Israel Health System, we actually have rich data. And a lot of researchers in, you know, in various institutes and capacities across the country contributed a lot to these studies. I also want to say that, like, this picture pretty much, you know, summarize my knowledge about the immune system going into the pandemic. So amazing research showed that vaccine work on a population level, including observational studies. You know, the Pfizer trial, the first Clalit paper, but certain populations were excluded from the main analysis, and we already had a talk about that today. And I want to talk about pregnant women, both in terms of safety and effectiveness of vaccines, and frail individuals with pre-existing conditions. So specifically, I'm going to talk about inflammatory bowel disease patients. So this is one facet I want to talk about, and the other one is that vaccination offers protection not only for the person who got vaccinated, but also to its surroundings. So when I got vaccinated, not only I protected myself, I also contributed to the protection of my wife and daughters. And while this sounds really logic, when I teach causal inference, like the first lecture, I say that all the causal inference standard methodology relies on an assumption we call no interference, which says basically that my treatment could be vaccine, but any treatment does not affect other people, which is not the case here. So I want to talk about vaccine indirect effects. So what I'm going to do next, I'm going to describe 3 studies about vaccine direct effects, and I want to highlight the challenges with 3 different collaborations that I've been involved in, and I want to highlight the methodological challenges and how did we overcome them. Okay, so starting with vaccine effects in inflammatory bowel disease patients. So this is as part of a collaboration with Sha'arei Tzedek and the Israeli IBD research nucleus that I've been involved in for more than 2 years. And, you know, I Googled in preparation for this talk, I Googled the IBD or infectious bowel diseases COVID-19. And in all the websites that I got, like the entire first of pages, it's like, you know, UK COVID, Crohn's and colitis. They all say whether it's effective. They all ask, you want to know whether it's effective. And the second question is, how the vaccine going to impact my Crohn's disease? Okay, so this is the first question. And the background for it is that IBD patients are more hesitated to get vaccinated, were and are more hesitated to get vaccinated because And we heard about it in the first lecture because it's possible that vaccine-triggered immune activation could trigger immune dysregulation and thus exacerbate IBD. I hope this makes sense to you. So we had twofold goals. The first, whether mRNA vaccines effective for IBD patients, and the second, whether they are and how they impact IBD severity, like flares, stuff like that. So a lot of like vaccine studies, vaccine effectiveness studies, observational studies, used matching. So you take vaccinated people, you find someone similar to them, which is unvaccinated, and you match them together. And the idea is that if you find a difference within these matched groups, between the matched groups, but within this matched sample, you can attribute this difference to the vaccine and not to any other background factor, which makes a lot of sense. The problem is that once we thought to learn to implement this in IBD patients, it was really hard to compare vaccinated, unvaccinated IBD patients for the reasons that I said. So those who were more hesitated were maybe people with more severe disease. And when we match people with vaccinated to unvaccinated, we also want to match on disease severity. So we had like two problems. It's really hard to find large sample sizes, you know, big data. When we try to learn effectiveness of vaccination, of vaccines, so the infection rates, at least pre-Omicron, is too low for us to be able to detect something with small numbers. So we had about 700 people, which is not enough. And there was the question, how do we adjust to baseline disease activity? You have complete medical record. What do you do with that? So our first solution was to do a kind of different analysis. What we did, we matched vaccinated IBD patients to vaccinated non-IBD patients. Okay, so we found similar people that are both vaccinated, but some are IBD patients and some are not IBD patients. And we were hoping to see that the infection rate is the same in both of these groups, because this would be indicative that the vaccination works similarly in both of these subgroups or populations. And to explore potential bias, we did the second analysis in which we matched unvaccinated IBD patients to unvaccinated non-IBD patients, where the idea is if there is any differences, if there are any differences between IBD and non-IBD patients, we see it also in the unvaccinated group, not only in the vaccinated group. So this was the solution for the first problem. For the second problem of how to study disease severity when we need to match on like complete medical record, so we used an unsupervised machine learning algorithm to classify to classify IBD patients to different disease severities clusters or groups. We validated in a second paper that is coming out to see that these clusters actually are quite predictive of what's going next. So people in certain clusters are more likely or less likely to have flares or more intensive treatment. And then we use these clusters in the matching process. So one slide about the results. This is staggered follow-up between December 2020 and June 2021. So this is the alpha wave, right? I'm getting mixed. We saw exactly the same outcome rate in vaccinated IBD and vaccinated non-IBD. So the numbers looks really small, like 15 out of 5,000 people in both groups. And so it was really important for us to see this is not just the results of low infection rate. So we also looked at the unvaccinated IBD, and we saw that actually the unvaccinated IBD had higher outcome rate than the unvaccinated non-IBD, which tells us that if there were any bias in this experiment, it was in the opposite direction than expected, right? It seems like the vaccination prevented even more cases in the IBD population than in the non-IBD population. And since it was mentioned earlier today, these results were also consistent when we looked at, I hope I'm saying it correctly, in people that were on TNF inhibitors. So the results were consistent. Yeah, okay, thank you for nodding. Right, yeah. When we looked at the risk of exacerbation, it was similar. There was a slight increase, not significant, but a slight increase. So at the very least, we can say that if there is any effect size of the vaccine on worse disease severity, it's not too large. Okay, so that was study 1. Study 2, vaccine effectiveness in pregnant women. So pregnant women were not included in the original vaccine trial, like the Pfizer trial, Moderna trials. And also they were not including in the first large observational studies as a result, because the first observational studies would try to learn the vaccine effects, try really to mimic what happened in the RCTs. And what happened, and this was interesting in Israel, is after there were several critical cases, including a media coverage of death in late February of unvaccinated pregnant women. So I have even our putting here. So I even have our keynote speaker here saying that the problem was might have been that people were not vaccinated, like pregnant women are unvaccinated. So complications, COVID-related complications were far more likely, or severe complications were in unvaccinated women. And this really worked. So thank you for that, because what we see in this graph, I won't show it. What we see in the graph in the left is like weekly number of pregnant women vaccinated. This is a collaboration with Maccabi. So this is from data from Maccabi Tech, from Maccabi. And in the last week of February, there was like a jump of pregnant women who went following this media coverage to get vaccinated. So what were our challenges? So the first, so we did matching on a bunch of stuff that like day of vaccination, age, gestational age, residential area, parity, flu vaccine status. It's a well-known proxy for health-seeking behavior. So people who took flu shots are more likely to, let's say, put masks also, right? So, and how do we know it really worked with such a small data set? It was hard. So how do we know that we don't have any residual confounding? That's the question we asked ourselves. And the second problem, which is kind of unique to these vaccination studies in the past 2 years, is that once I do the matching, I start looking at each match at a different day. Let's say someone vaccinated in February 21st. I find a match, I follow up them both, and then boom, 2 days after, maybe the unvaccinated got vaccinated. And what do I do then? And this was a really severe problem in the pregnant woman cohort because all the staggering of the vaccination, right? The people were like vaccinated in really similar situations. So what did we do? We used something that is called negative control outcomes. For the experimentalist in the audience, it sounds completely sensible, but for people working on observational studies or with core data, it's maybe less clear. The idea is that we find something that should not be affected by the vaccine allocation. Specifically, we are lucky, it's kind of funny to say it, but we are lucky that the vaccine should not be effective in the first 10 or 14 days. We know it from the RCT, right? So if we see any difference between the two groups, the vaccinated and the unvaccinated, in the first 14 days, it shouldn't be due to the vaccine. It must be that our two groups are not comparable. And indeed, when you look at this graph, we look at the cumulative incidence, you can see that like the first 14 days, it's like we have the same line, and then they split, right? So when we did that, we were more calm or more relaxed to say that, okay, the difference that we see at the end, 70 days after follow-up, is a real difference of the vaccine and not anything background, because we use this thing that is called negative controls. Turning to the second problem of the staggered outcome, every time we had a matched unvaccinated person getting vaccinated, we did artificial censoring, which is something that we often do, we know how to deal with. We matched we censored, we ended the follow-up for both people in the original pair, but we took the person that were unvaccinated, now moved it to the vaccinated, set his follow-up time to 0, and found a new match for her. So essentially, we didn't lose people because every time someone in the controls got vaccinated, we moved him to the other group and found something new, someone new to match to them. Okay, so a couple words about. So this is a paper came out in JAMA last year, not more than that, obviously. 7,500 matches. I have some descriptive results here, but maybe the most important thing is that vaccine effectiveness is measured by adjusted hazard ratio was about 78%. The sample here of 7,500 people, we didn't see any severe adverse events, and we saw, and this was particularly important, same very, very low outcome rates for abortion, stillbirth, preterm, same median and IQR birth, week and infant weight, and I saw that just like 2 days or 3 days ago was the first study which was like looked at these outcomes at scale. Like I don't remember where from it was, maybe Denmark. I don't remember, like very large study that confirmed these findings. Okay, so this was number 2. Moving to number 3, the most recent one, an indirect protection of vaccines. So as I said, first lecture when I teach causal inference with math and all that stuff to graduate students in statistics, I talk about the no interference assumption. My treatment cannot be affected by other people's treatment. And my go-to classical violations is vaccine studies. I've been showing like tables, of vaccine coverage in India and Bangladesh against cholera and stuff like that, and showing that the treatment effect, the vaccine effect, really depends on which community you live in and whether the community is a high proportion of vaccinated or low proportion of vaccinated. So when the first studies about vaccine effectiveness came out, so the Pfizer trial is okay because no one was vaccinated, right? But once more and more people, especially in Israel, where we reached like high level of vaccination, more and more people got vaccinated, it was harder and harder for me to interpret the results because of this entanglement of direct and indirect effects. So the vaccine effect depends on whether other people were vaccinated. So what do? We tried, this is a collaboration with Clalit that came out in Science last month, I think. And the idea was that we separated vaccine effects into indirect effects and direct effects. Direct effects, it's everything we know about. It's exactly what we estimated in 2 other studies. Here we focused on the indirect effects of other people's vaccination status, and we try to study the impact of household vaccinations. So how people in my household getting vaccinated affect other people. And the truth is, even that was a hard problem because it's really hard to target a reasonable effect because household size, which is very variable in Israel, and ages, determines number of potential vaccinated or recovered. So in a household of 2 people, you can have 5 vaccinated people. And the protection that you expect from a house of 5 people, all 5 are vaccinated, it's not the same protection of a household of 10 people with 5 vaccinated. So it was really hard to be able to say something which makes sense. So for that reason, we focused on children and parents. And what we did, we looked at the indirect effect and the direct effect first of the booster shot. So this is the Delta wave. And we look at 180,000 unvaccinated children from 76,000 distinct households. And what we saw, first we saw that there is a direct effect, about this 86%. This is the usual direct effect that was published in other studies as well. It was comparable to other studies. But we also saw a really significant, not only in the statistical sense, it's a reserved word, but of the indirect effect. When a child to 1 vaccinated parent had 20% more protection, so 20% less likely to get the disease, where a house with 2 parents was 60% protection, which means that when 2 parents were vaccinated, they gave a really serious protection to their children, and the analysis was very rigorous. I'm not talking about the nuts and bolts, but there is a lot of dependencies, right? Because I look at people at the same household, kids at the same household, but we did a very, I don't want to say sophisticated, but let's say a rigorous and careful analysis to make sure we can overcome these problems. And we saw actually analogous results for the alpha wave. So there was indirect effect, indirect protection also for the alpha wave. 3 minutes. So I have 2.5 minutes to thank my collaborators at Sha'arei Tzedek Hospital, Clalit, Maccabi Tech, Tel Aviv University. There is a union or intersection or whatever of the people and the project. And yeah, and thank you.
Thank you very much, Daniel. Okay, very interesting. There are questions for Daniel? Okay, wait, I want to comment. This is very interesting, especially these household studies, and there are classical cluster studies on vaccine, even effectiveness on typhoid, for example, in India, and all these studies that this kind of approach has been taken. Great, and was a very easy delivery, so that was.